My name is Manar Askaryy, and I am honored to present, to be the moderator of this session, Keratoconus Mission Possible. As we all know, keratoconus is a debatable subject in which there is many challenges, and in this session, we are going to answer different management technique of challenging cases of keratoconus. And as the Arab Women Ophthalmic Leaders Society fights disparities between female and male ophthalmologists, so in this session, we are delighted to invite two eminent speakers, Dr. Hani Hilali and Dr. Mohammed Katib, to join us with the Arab Women Ophthalmic Leaders Society. My first presentation is RGP fitting in challenging cases of keratoconus. As we all know, the normal human cornea generally has a prolate configuration which steepens in the center and progressively flattens towards the periphery. When a disease or trauma or surgery alters the condition, the corneal shape, fitting of this cornea becomes a challenge for even the most experienced contact lens practitioner. There is two major types of contact lenses, the scleral lenses and the corneal lenses. The corneal lenses include the traditional PMMA lens, soft lens, RGP lenses, and combination of rigid and soft material. The scleral lens is the least popular design, and it is indicated in advanced keratoconus and in severe irregular cornea, and it is very easy to insert and remove and correct any type of corneal irregularity and easy to store, but it is time-consuming, difficult to fit, and difficult to handle due to its large diameter. The corneal lens, including the traditional PMMA, which is rarely used nowadays because it causes corneal edema, as it doesn't allow any oxygen to penetrate. The soft lenses, it is a material of hydrogel or silicone hydrogel. It is indicated in early keratoconus and mild degree of corneal irregularities. It affords higher level of comfort and long wearing, but it can cause a risk of neovascularization, and it cannot be used in advanced cases of keratoconus. The rigid gas permeable lenses is the first choice for correcting irregular astigmatic cornea, and it aims to modify the irregular conical surface of the cornea to a regular optical surface. There is different design of RGP lenses, which is known by the 1 curve, the 2 curve, the 3 curve, and the multi-curves, which are known by the Maguire contact lenses with a 3 diagnostic lens set for the nipple oval type of keratoconus. The ROSE K2 design, it is a special type of keratoconus with a base curve range from 4.7 to 8 millimeter and with a diameter range from 7.9 to 10.4 millimeter. The optical zone in a conventional or ordinary RGP contact lenses varies from 7 to 8 milli diopter. However, in ROSE K lenses, the optical zone is small to fit a small cone or irregular corneas. The hybrid lens, it is an RGP lens surrounded by a soft hydrophilic skirt, and it is indicated when RGP lenses are intolerable. It provides better visual acuity and better centration, but it may cause giant papillary conjunctivitis, corneal edema, and there is limitation for the parameter of fitting, and also the cost is very high. The challenging corneal cases for fitting of RGP lenses is keratoconus, pellucid marginal degeneration, keratoglobus, post-keratoplasty, post-refractive surgery, after intakes, and highly asymmetrical cornea as a post-traumatic. As we all know, keratoconus is a non-inflammatory corneal thinning disorder, which results in a conical protrusion of the cornea. It is usually bilateral but asymmetrical in 15% of cases at its start and puberty and progress until the 3rd to 4th decade of life, and the prevalence is high with the corneal topography. Patients with keratoconus usually complain of frequently changing of spectacles, poor repeatability of subjective refraction, blurred distorted image, ghosting, glare at night, and halos around light, and by examination, scissoring of the retinoscopy reflex, distorted keratometric miles, and droplet oil with the red reflex. The treatment algorithm of keratoconus, we start by RGP fitting to see the best corrected visual acuity, but if unsuccessful, we consider other modalities. If any progression of the corneal, of the K reading, we just do corneal cross-linkage, which is not a cure for the disease, but it stops or halts the progression of the condition. Then to achieve a better visual acuity, we can shift to RGP lenses. If tolerable, we can just do observation. If not, we can shift to intakes or corneal transplantation in severe advanced cases. For the fitting protocol, we just do preliminary examination. We reassure the patient and explain the nature of the disease and the progression and prognosis of the condition. Then we do full slit lamp examination and then corneal topography. We classify the keratoconus in terms of radius of curvature of the anterior cornea into early subclinical, moderate to advanced, and advanced cases of keratoconus. The most common types is the moderate and moderate to advanced, ranging from 49 diopters to 56 diopter. Also, we classify the keratoconus according to the cone shape into the nipple type, the oval type, and the globus type. The nipple type is 3 to 5 millimeter with a lower nasal quadrant, and the oval type is 5 to 6 milli in the infratemporal quadrant, and the globus type is more than 6 milli and occupies 75% of the cornea is affected. The golden rule for fitting of RGP, we start by corneal topography, we do fluorescein pattern, and for a successful contact lens fit, it allows the patient for wearing the contact lens for many hours and maximize vision and keeps the corneal integrity intact. For the fitting philosophies, we have 3 types of fitting for RGP lenses: the flat fit, the steep fit, and the 3-point touch, which is the ideal form of fitting. For an ideal fitting, we just starting by anesthesia, and we choose the correct base curve, which is 0.2 milli steeper than the average 2 meridian, and then we do a fluorescein stain and evaluate the central fitting. Then we do over refraction and then visual assessment. For ordering any RGP lens, we just need the parameter of base curve, diameter, and power. Follow-up examination. Patient should be re-examined 2 weeks after taking the lens. Regular routine 6 months examination are extremely important, and lens should be repolished at least annually or even 6 months after taking the lens. If apical staining is present, the lens should be refitted steeper to avoid long-term complication, even if the patient is comfortable with their existing lens. The National Keratoconus Center Foundation urges the patient to call their eye care provider if he complains of any of blurring, redness, tearing or discharge, inability to keep the eyes open, and severe photophobia and white spots on the cornea. For the low cone, we just increase the diameter of the lens and flatten the base. For the superior cone, we decrease the diameter and steepen the base. For the small steep cones, we flatten the base and decrease the diameter. And for astigmatic cornea, we decrease the diameter or use the toric soft contact lenses. The piggy bank lenses, it is a rigid lens fitted on the top of a soft lenses. It is used when intolerable RGP lenses are used or central apical staining, and when RGP lens has to be fitted very flat to obtain good visual acuity, but it may cause complication as hypoxia, edema, and difficulty during handling. For the fitting of piggyback contact lens, we fit the RGP lenses approximately 0.3 milli flatter and 0.5 milli larger than the ordinary lens, and it should not be the first option unless previous tolerance issue or fitting issue for the patient. For the pellucid marginal degeneration, we use a very large diameter lens, scleral lens, superior cone, or rose-K or hybrid lens. And we choose the first lens 0.3 milli flatter than the steepest meridian, and the diameter should be 1 milli inside the limbus, and location tend to be allocated over the steepest point of the cornea. Post-keratoplasty is the most difficult fitting due to irregular corneal profile with higher degree of astigmatism, and diameter is the biggest factor for controlling the centration. It is indicated when the best corrected visual acuity cannot be achieved by spectacle correction, and we use the rose-K or reverse geometry or piggyback contact lenses for the fitting post-keratoplasty. It is a reverse geometry with a large optical zone with steeper peripheral curve than the ordinary rod-K graft. For the standard RGP, the fluorescein pattern, the 3-point touch is the ideal touch for fitting or even after keratoplasty. After intakes, the irregularity in elevation is created after intakes due to difficulty in centering the lens and problem with bubbles. We can use glasses or soft toric lenses or rose-K2 lenses. The most common reason for pooling or tolerance is the edge lift, the ignored corneal astigmatism, poor lens maintenance, allergy, motivation, and handling. For comfort of the patient, we increase the edge left, the prescribing lubricating drops, and always use a storage conditioning solution with a specific protein inhibitor. The problem of the contact lens is it can be broken, it can be riding up, mucus and debris under the lens, and the cost. When to shift, when it is completely intolerable lenses and failed fitting, and with all available design of RGP lenses. And don't forget that graft, much more difficult to fit than keratoconus. Try any alternative option before referring to graft. Thank you.